All right, our next presentation is by Krishna Jain regarding setting up a profitable and successful wound care center in your office.
Yeah, thank you for inviting me to talk about this important subject. These are my disclosures. So there are 4 pillars of limb preservation: medical management, revascularization, wound care, and neuropathy management. The last 2 days we spent talking a lot about revascularization, and wound care is obviously extremely important, so it's good to have this session talking about managing how to provide good wound care. One thing one have to recognize that up till now, most of the wound care was being provided in the hospitals. And as more and more care is being transferred out of the hospitals, it's very important that we have successful, profitable wound care centers in an outpatient setting. So what are the main types of wounds that are treated in these outpatient wound care centers? Diabetic foot ulcers, venous ulcers, ischemic ulcer, pressure ulcers, and the previous presentation, Dr. Gottlieb talked about many other kind of pathologies that can cause ulcers. So ADA shows the amputations are on the rise in the United States. As high as 80% of non-traumatic lower limb amputations happen due to diabetic complications. An individual who has an amputation probably has a worse chance of 5-year survival as compared to cancer. And they're also more prevalent among the people of color. So there is the issue about the care that is provided in different communities. So what are the benefits of a multidisciplinary wound? We heard earlier about limb preservation centers, and that is, I'm a firm believer of that. So benefits of multidisciplinary wound care center on the volume and outcome of a vascular surgery practice. The volume, when you have a multi-specialty practice or a multidisciplinary practice, the volume of the lower extremity intervention increases by 64%. At 1 year of follow-up, major amputation rate was significantly lower in the group after the wound care center was open as compared to before the wound care center existed. The impact on outcome by establishing an integrated interdisciplinary surgical team to care for the diabetic foot. This paper came out a while ago. 45.7% reduction in below knee amputation, and 1/3 of the patients required vascular intervention. Structured health care for subjects with diabetic foot ulcer results in a reduction of major amputation rates. As you can see that the amputation rate decreased by more than 75%. So it is proven that a multi-specialty approach helps prevent amputations. And if you look at this registry, which is a very large registry, 97% of the patients who had venous ulcers have possessed a surgical correctable disease. So when you're running a wound care center, it is not just the profitability or viability of wound care center that matters. What matters is what is the outflow for the other procedures that come out of that. Obviously, you're looking for good results. At the same time, you have to make sure it's financially viable. So as a result of a wound care center, a lot of patients end up with having interventions and other procedures, which makes overall a very profitable limb preservation center. So what do we do? Physicians perform minor surgical procedures in the clinic. When you have a wound care center, they provide determined need for surgical intervention. Iron case managers, patient coordinating all patients of the care. They manage clinical pathways. EMR tracks patients. There are certain EMRs which are very specific to wound care, which are important to instill because you can follow up your patients, have data which you can publish, and just show your results. Multidisciplinary team develop individual treatment plans. Multidisciplinary team is extremely important because, as you know, in a diabetic foot ulcer, if you don't have an ID consult early on, by the time if there's a multiple organism infection in the foot, despite good revascularization, you may lose a limb. Specialized training in advanced wound care and hyperbarics. There is a talk later on about hyperbarics, aggressive treatment with surgical focus, approach based on proven clinical guidelines. Extremely important that we have to use proven guidelines and supported by evidence-based medicine. So in a program model, Typical hours are Monday through Friday, 8 a.m. to 5 p.m., 2 clinic sessions, 1 a.m., 1 p.m. So basically, we look at 10 shifts, so to speak, how to fill those 10 shifts, 1 or 2 physicians per clinic session, projection of expected number of new wound care patients. When we create a pro forma, we look at starting with 275 new patients, and average treatment, duration of treatment is about 6 to 12 weeks. And hyperbaric patients, 3 to 6 patient treatments per day, and average 30 treatments per patient. This all goes into your financial pro forma when you're looking at the viability and the profitability of a wound care center. With the HBO chambers, there are 2 HBO chambers we start usually in a clinic. Ultimately, some of them we have to increase to 3 or 4. There's a much more extensive talk later on about HBO treatments, but it is 100% oxygen at 2 to 3 atmospheres, systemic delivery of oxygen. There are also newer systems now which will talk about local perfusion, local oxygen therapy on an outpatient basis. The results are early. Daily doses 5 times a week. Most conditions receive 2 2-hour treatments and 30 to 60 treatments usually, depending upon diagnosis. Primary indication, there are about 13, 14 indications approved by Medicare, but in our context, is usually non-healing diabetic wounds, Wagner 3 or worse. Radiation injury in a wound care center, about 40% of the patients or so are there because of radiation injury, and not necessarily because of the ulcers in the feet, and compromised skin flaps. Sources of referrals, self-referral, a lot of patients refer themselves, PCPs, skilled nursing facilities, discharge planners, case managers from the hospitals. When the patient is being discharged, they need to have a home where they can get treatment for their wounds. Home health nurses, a lot of patients continue to get home health care for wounds. They ultimately need to come to the wound care center for faster healing. And physician specialists, they would refer. We get a lot of referrals from infectious disease doctors. So I believe, and as one of the previous speakers talked about a limb preservation center. So you need to have more than a wound care center. You need to really look at the concept of a limb preservation center, because that's what our goal is, to preserve limbs. So what is a limb preservation center? It focuses on the treatment of diabetic foot ulcers, diabetic foot infections, peripheral arterial disease, and others at-risk conditions to prevent unnecessary amputations. It requires intensive treatment of medical complex patients, aggressive physician-surgeon team, surgical intervention focused, both from the podiatry standpoint of view, because a lot of surgical podiatrists do wonderful things operating on the feet, as well as revascularization is extremely important, whether it be percutaneous or whether it be in the hospital. 75 to 80% of revascularization are endovascular, and they're being done on an outpatient basis. And then continuum of care between medical management, wound care centers, and intervention to improve flow and manage neuropathy. Neuropathy, there's a new device I saw in the second session. There is a talk about that. Neuropathy is extremely important in managing diabetic feet ulcers. So how do you execute that? Physician needs to be committed. It's not a part-time job. You need to be committed to limb preservation, wound care center. You integrate with the practice. There are various models that you can create, whether it be within your own practice or create a separate LLC or DBA. There are various mechanisms to do it financially. You need usually 1,500 to 3,000 square feet. Sprinklers are important, because without sprinklers, you cannot put in hyperbaric chambers. And without hyperbaric chambers, a wound care center will not turn a profit. There was a time then for the HBO treatments, the outpatient Medicare used to pay like $200 for the HBO treatment, and now they pay what they pay the hospitals, very comparable to that, or sometimes a little bit more than what they pay to the hospitals. And that's why the wound care centers have become sustainable and profitable. You need a capital investment for space, equipment, supplies, and outreach program. Economic success for the physicians, there's additional revenue stream from clinical visits and procedures in wound care center. Additional revenue stream for MDs from hyperbaric supervision, because that is a professional component which is kept by the physicians. Increase in surgical volume, increase in definite 100% increase in endovascular procedures, and able to provide longitudinal care. And you can control your schedule, preventing burnout. So acts as a magnet for referrals, attracts diabetic patients with foot ulcers, provides the ability to treat more complex patients. It generates greater revenue to support and grow the OBL, ASC, an entire limb preservation program. It definitely improves patient care. You become a center of excellence. In your community, if you have competitors, if you provide the total care, you truly become a center of excellence, and you can be a leader in the field, not just locally, regionally, but also nationally. Thank you very much.